saying that our opponents are evil overlords roaming over desert lands, leading teams of orcs. We are saying that we are the underdogs. We are the young, up-and-coming people questioning the status quo that has been ingrained, that is being upheld by those who just refuse to change. So why do you lower the blood pressure? Well, you lower it because it's in the guideline. You do what's in the guideline. And there it is, we should lower the blood pressure. But why is it in the guideline? It's in the guideline, as was already pointed out, because higher blood pressure patients were excluded from the pivotal trials. And while there was a little bit of something around IST that you could enroll patients who were having blood pressures a bit higher, we couldn't find any evidence that any of those people were actually treated. Everyone had blood pressure that looked like below 185. And even had we found any evidence of these people being treated in these trials, none of these trials actually tested the question as to whether we should use TPA in patients with blood pressure over 185 versus not, or whether we should lower the blood pressure. So this question actually hadn't been answered in these trials. So what we have is we have inference. So these guidelines are based on the inference that because they weren't included, we shouldn't use it. That's not class 1 evidence. So we shouldn't have strong recommendations on this point. We should do what we're doing in the Australia-New Zealand guideline, which is acknowledging that not lowering the blood pressure in that situation, or rather lowering the blood pressure in that situation, is purely consensus-based on the best evidence we have. So we have some doubts. Why are we so worried about blood pressure? Well, high pre- and post-thrombolysis blood pressure is associated with worse outcomes and increased rates of ICH. We don't contest that. So let's look at these studies a little bit more, a little bit closer. So high pre- and post-TPA blood pressure is associated with more SICH and poorer outcomes. But in this particular study, they also found that the use of antihypertensives did not show any significant difference in SICH rates. So the blood pressure is associated, but treating it doesn't seem to make a difference. In this paper, the authors found that pre-TPA high blood pressure is associated with poor outcomes and increased SICH rate, but the SICH rate could not explain the worse outcomes. And in this paper, it didn't matter whether you were treated or not. Everyone with high blood pressure had treated with thrombolysis. So the thrombolysis wasn't what was changing the outcome, it was the blood pressure. So I invite you to look at things from a slightly different angle, as I sometimes like to do. When you turn things upside down, you actually find some truths, such as that New Zealand is in fact the center of the world. And taking that into account, we propose that increased blood pressure is purely an epiphenomenon, and that lowering it makes us feel good, but not necessarily the patient. In fact, dropping the blood pressure, now you were falsely reassured that that's all okay, but actually there is some good evidence that dropping the blood pressure is bad. As early as NINDS, not only dropping it is bad, but dropping it abruptly is bad, and let's face it, we've known this for a while. We've done some work ourselves showing that in our effort to keep the blood pressure really well controlled, what we do is we drop it so low that we're actually really worried about it. And then there's a nice study from Canada showing that BP lowering before thrombolysis was associated with a reduced chance of excellent outcomes. And as already mentioned, Interact 4 showed that in the pre-hospital setting, lowering blood pressure resulted in worse outcomes. And yes, maybe the blood pressures were a little bit lower, but lowering it was bad. And of course, you do know who was involved in that study, and now Craig is looking a little bit more worried.
So thank you, Anna. Being the smallest potato in the stage, I'll try to carry on. So, sorry. We're trying to thicken the pot a little bit by showing you data with LVO cases. So not only in all AIS cases, but cases who have received thrombectomy, we know that the blood pressure before treatment is associated with a bad outcome. And especially bad if you lower it. In this Korean study, it showed that if you lower the blood pressure by medication 24 hours after recanalization, it is actually associated with 3-month poor outcome. And a meta-analysis that analyzed 4 studies also showed that if you have an intensive blood pressure lowering, which is down to 120, there is a much lower functional independence rate compared with those who were not intensively lowered. Why is that? This data from this Korean paper showed us that because any fluctuation in blood pressure following recanalization actually significantly increases the penumbral tissue loss, and this is probably the reason why we're seeing such bad outcome behind these patients' data. And truth, I'm sure that Greg knew that we'd be using this paper, and while we agree that this is actually just an observational data, there is something to take away from this paper. This paper analyzed patients who were actively having the blood pressure lowered before TPA, or they adopted a wait-and-see method. Either wait for the blood pressure to come down spontaneously, or not to give at all if it's not down to the approved rate. As Craig has shown you, there is a shift towards favoring groups that have not had their blood pressure lowered, but we're not actually telling you that it is safe or not to do so. We're looking at the baseline. If you look at the baseline, the stroke severity of both groups of patients is actually comparable. If you look at the door-to-needle time, there's also no prolongation of door-to-needle time. You may wonder, are those patients who were not having the blood pressure lowered received more thrombectomy? But that is not the case. The rate of thrombectomy is actually the same in both groups, and also naturally, patients who did not receive TPA in the non-lowering group is much lower, but then again, that did not contribute to the result differences. What we would like to take away from the study, from the same chart, is how the blood pressure actually drops much more drastically in the group that was actively lowered. You can see that it's significantly lower 6 hours and 24 hours, 6, 12, and 24 hours after the treatment was given, even they were all given the same medication. What we're trying to infer from this is that blood pressure is not something you can easily predict. Anna has showed you the slide, but in addition to pre-treatment blood pressure, the post-treatment blood pressure is also very hard to control in most patients. I'm sure you have encountered cases where you get the blood pressure just right down to the level you want, give the bolus, and the blood pressure just shoots back up. So I'd like to use this little cartoon to end our little part, where sometimes when you're trying to bring down the blood pressure, it will just be like a punching ball. You bring it down, it comes up, you bring it down, it comes up, and if you psychologically bring that level down below 185 just for your bolus to work, you can see that the blood pressure actually shoots back up. And sometimes given the same dose, you'll actually knock it down far too much and the blood pressure goes way too low. So you can't really predict where the blood pressure will go if you actively lower it with pharmacological treatment. I'd like to finish my part with this slide, and this is actually a question of whether blood pressure is something we should target here. Professor Toyoda, please correct me if I'm wrong. This is actually a myth from Japan, the myth of the Namatsu, because years ago people thought that earthquakes were caused by this giant catfish thrashing underground. But they know that the catfish is just there, it signifies an earthquake is coming, the catfish is not the cause of the earthquake. So perhaps blood pressure in bad outcome in acute ischemic stroke patient may be the same thing. Maybe it's just, as Anna has said, an epiphenomenon that shows that patients may do worse if the patients have high blood pressure, but it may not be something that we should actually bring down. So this is our concluding slide here. So of course, our slide thinks that we should place some doubt in this long-standing practice of lowering blood pressure, because there's data that show that if you lower the blood pressure too low, it's associated with bad outcomes, hypotension, penumbral loss, and the guidelines that we have are actual inferences from data that do not directly study whether TPA is bad with or without lowering the blood pressure. And so I guess we're not here to tell you that it's absolutely safe to do thrombolysis without lowering blood pressure, but just like in a courtroom, we're just throwing some doubts in your mind, maybe some significant ideation, whether there's a reasonable doubt that we should still be following the guidelines we've been following all along. So that's the end of our part. Oh, sorry. So we still have also this slide, which is to hopefully achieve what we achieved with bringing down the towers.
now welcome the rebuttals, and first Prof. Anderson and Prof. Toyoda.
Look, I commend the opposition for their valiant attempt, but did you notice towards the end they had doubts themselves? I don't think they really lacked commitment. This is a serious matter, this debate. I enjoyed the cartoons and video, but ultimately it's scaremongering. It's pure scaremongering. They didn't come up with any tangible quality evidence to justify a change. If we are to go through life again, like we did 40 years ago, just observing people, we'll never get anywhere. You need randomised controlled trials. Where is the randomised controlled data that tells us to change what we've been doing for 30 years, is in the licence, it is in all guidelines? Where should we change? We need a trial. Don't extrapolate very intensive blood pressure lowering. That was not the question. The question is, should we shift from the guideline 185? It's not a question about should we go down to 120. That's harmful. I acknowledge that. Focus on the question. Don't move from having randomised evidence, and be wary of scaremongering junior people in our faculty.
Simple question for you. So you allowed 185 or higher for the patient planning thrombolysis. And after starting thrombolysis, you still okay, even if SBB 180 or more for the first 6 hours, 12 hours, 24 hours. It's dangerous. So, one more. Stefan, I want to say one thing. Don't misunderstand Stefan's last slide regarding the big fish is Namazu fish, not whale. So, okay, so thank you.
Well, I guess I would suppose there's a problem when you start with an argument that was never based on randomized controlled trial data. So we know that we shouldn't be treating, we have no evidence that we should be treating people with a blood pressure over 185. But we also don't have very good evidence that tells us that it's safe to aggressively, or we actually, several guidelines say you shouldn't aggressively treat it, and people do anyway. People with whatever you have, you're going to look at that blood pressure down to 185 because something magically happens at 185 that it's safe. And what we're saying is, with truth, is there's serious doubt cast on something that is in the guideline for not very good reasons, that's been overstated by saying it's a strong evidence-based recommendation when it isn't. It's just a practice point. And all we're saying, we completely agree. We would like more trial data. Why don't we do what's safe and wait until we have trial data that actually proves the point one way or the other, rather than continuing to do something that we're just doing because we've always done it. When has that ever been a good idea?
So Anna has said all I want to say, but I'd like to thank Professor Toyoda for pointing that out. And to answer your question, there's actually been something on my mind too, is whether we should actually psychologically lower that blood pressure to below 185, because sometimes what we do is we wait until we get that down and then we give the bolus, but then it's actually high up. So it may also be another point where we may just give the bolus anyway, and you have to continuously give the thrombolytics, the blood pressure lowering afterwards anyway. So it seems on the premise that whether you should lower the blood pressure before you give the TPA doesn't seem to be a very practical step sometimes, because it actually may delay your door to needle time.
I'd like to thank all the speakers, and we're going to go with applause. And Vincent has a very technical device there that he's recording the volume of your applause. And so I will ask you first for the opposition, those who are voting for the opposition for this statement. We don't hear anything at all.